The American Brain Tumor Association is pleased to welcome you to our webinar series. Our webinar today will discuss understanding meningioma tumors, update in treatments and trends. My name is Ruth Lederer. I'm a program manager and care consultant here at the American Brain Tumor Association, and I'm honored to introduce our speaker today, Dr. Mark D. Johnson. Dr. Johnson is an associate professor at Brigham and Women's Hospital, an associate professor of surgery, Harvard Medical School, a director of neurosurgical pain management program at Brigham and Women's Hospital, and director of the Johnson Laboratory at Brigham and Women's Hospital. Dr. Johnson attended Harvard Medical School, where he earned an MD and a PhD in neurobiology in 1995. He subsequently completed a residency in neurological surgery at the University of Washington in 2003, and later returned to Harvard Medical School and Brigham and Women's Hospital, where he specializes in the neurosurgical management of brain tumors. Dr. Johnson also directs an NIH-funded research laboratory focused on the genomics, proteomics, and cell biology of meningiomas and gliomas. Dr. Johnson is also the recipient of numerous awards, including the Sontag Distinguished Science Award and the NIH Director's New Innovator Award. With that, thank you very much for joining us, Dr. Johnson. You may now begin your presentation.
Thank you, Ruth. Good afternoon, everyone. We'd like to talk today about some of the recent advances in understanding meningiomas and in the treatment of these tumors. As many of you know, meningioma is the most common primary intracranial tumor. It arises from the coverings of the brain, which are also called the meninges. Meningiomas are present in roughly 1 to 3% of the population, but they're usually asymptomatic. Most often, these tumors are benign, slowly growing lesions, but they can be aggressive in 15 to 25% of cases. Meningiomas cause significant disability and death primarily by pressing on surrounding brain structures. And in some cases, they can also invade the bone of the skull. The two MRI images shown here on the left depict a meningioma arising from the sphenoid wing of the skull. The yellow arrow points to the tumor. You can see that the tumor is quite large, and there is some surrounding edema, and it compresses the brain and pushes the brain to the opposite side. The panel on the lower right is an autopsy specimen from a patient who had a meningioma. The membranes surrounding the brain are shown here. This is called the dura. It's been opened. You can see the underlying brain, and this is the meningioma, which is attached to the dura. You can also see the indentation in the brain that was caused by this meningioma. This is data from the Central Brain Tumor Registry of the United States. It lists the incidence of meningiomas, or rather the percentage of meningiomas and other brain tumors. You can see that meningioma, shown here, is the largest subgroup. It comprises approximately 35% of all primary intracranial tumors. The incidence of meningiomas increases steadily with age. And interestingly, these tumors are more common in women than in men. This is true at all ages, although the ratio of tumors in women to tumors in men does decrease after about the 4th decade of life. The reason for this female predominance is unclear, although some have hypothesized that it may have to do with female-related hormones such as estrogen and progesterone. Meningiomas can present with many different types of symptoms. The most common symptom is head pain or headache, and that occurs in about 43% of patients. Visual disturbances, including visual loss due to anterior skull-base meningiomas, and cognitive deficits occur in about a third of patients. Roughly a third of patients present with seizures as well. Motor deficits, such as weakness in an arm or leg, are somewhat less common, and balance difficulties associated with cerebellar problems also occur in about a quarter of patients. Speech difficulty occurs in a minority of patients, and then there are a variety of other symptoms that can occur. There's been a lot of interest in trying to determine what causes meningiomas, and some of these studies have looked at risk factors that appear to be associated with meningioma development. I'd like to classify those studies and the evidence for them into three categories. The first category consists of strong evidence. So at the present time, there's strong evidence that radiation exposure can lead to the development of meningiomas. There was a very famous study of children in Israel who were radiated, their scalp was radiated for treatment of tinea capitis. And many years later, they examined these children and they found that those who received such radiation had an 8 to 10-fold increased risk of developing meningiomas. In the recent lay press, there's been some question of whether dental x-rays might also predispose to the development of meningiomas. Although the data here is suggestive, it's not quite conclusive at this time. But I think it's reasonable to be concerned about any kind of ionizing radiation and how that might affect meningioma development. There's also strong evidence that patients who have a family history of meningioma may be at increased risk for developing a meningioma themselves. And this is probably because of genetic factors. And as we will discuss later, there are some genes that have been discovered which predispose families to developing meningiomas. The second category of evidence for risk factors predisposing to meningioma I would consider as moderate evidence. Hormone replacement therapy has been associated with meningioma in several studies. These are primarily retrospective studies, and so they don't quite meet the criteria for Class 1 evidence. Nevertheless, it is true that meningiomas do have hormone receptors on their cells, and activation of these receptors can regulate growth. In addition to hormone replacement therapy, there's moderate evidence that a history of other cancers, especially breast cancer, may be associated with an increased risk of meningioma. Again, recent genetic studies indicate that meningiomas contain many of the same abnormal genes that are found in other cancers. And so it's quite likely that those genes can predispose not only to meningiomas, but also to other cancers in some patients. This is likely the explanation for this relationship. And then the third category, I would say, provides weak evidence or no evidence for an association. Following on the heels of the hormone replacement therapy question, many have investigated whether oral contraceptives are associated with an increased risk of meningiomas, and the majority of studies suggest that this is not the case. There's also been recent interest in whether cell phones may be associated with the development of brain tumors, including meningiomas. There have been numerous studies on this, but none are conclusive to date. And I think it would be safe to say that the evidence suggests that if there is a relationship, it is a weak relationship. And finally, I'm often asked by patients in the clinic whether a remote head trauma may be associated with their meningioma. To my knowledge, there's no clear evidence that head trauma is associated with the development of meningiomas. There have been, over the past few years, some exciting developments in understanding the genetic and genomic origins of meningioma. In particular, two studies that were published earlier this year, one in Nature Genetics and the other in Science magazine, have used high-throughput deep sequencing techniques to categorize the mutations that are present in these tumors. For many years, we have known that neurofibromatosis type 2 is a disorder that predisposes to meningiomas, and the gene NF2, which is responsible for this, has been found in somewhere between 40 and 50% of meningiomas. However, the cause of the other meningiomas was unknown until recently. This is data from a recent article published in Science, where they analyzed the DNA of a large number of meningiomas, and they identified new genetic mutations that appear to be responsible for the development of meningiomas that do not have NF2 mutations. So you can see here that there were a large number of tumors that were assayed. Each tumor is represented by one of the vertical columns. About half of these tumors showed a loss of chromosome 22, and most of those showed a mutation in the NF2 gene. But there were a large number of tumors that did not show a loss of chromosome 22 and did not show mutations in NF2. As it turns out, many of those tumors have mutations in a novel gene called TRAF7, and other mutations were also identified. There were mutations in a gene called KLF4, AKT1, and smoothened. In particular, the AKT1 and smoothened genes have been implicated in other cancers. So this new genetic information is very exciting because it now provides other avenues for research which are aimed at targeting the growth pathways in meningiomas. There is another exciting finding that came out of this work. It turns out that these different types of meningiomas tend to occur in different parts of the head. So the NF2 mutated meningiomas tend to occur posteriorly. The TRAF7 meningiomas tend to occur along the sphenoid wing, and the AKT1 and smoothened meningiomas tend to occur on the midline. And this explains some clinical observations that tumors which occur more posteriorly behave somewhat differently than those that occur more anteriorly. You can see that pictorially depicted here. The TRAF7 mutated tumors tend to occur more anteriorly, and the NF2 mutated tumors tend to occur more posteriorly. Now, I mentioned previously some evidence that a family history of meningiomas can predispose to the development of meningioma. At some level, we've known this to be true for some time. There are some known genetic disorders that predispose to the development of meningiomas. The most well-known of these is neurofibromatosis type 2. Lesser-known syndromes include Cowden syndrome, Lee-Fraumeni syndrome, and Werner syndrome. These latter three syndromes are what we would characterize as cancer syndromes. Patients not only develop meningiomas, but they are at risk for developing other types of cancers. And these genes can be passed from parent to child, and as a result, cancer, quote, runs in the family, unquote, and meningiomas can be found in many members of the family. Recently, there were some new mutations that were discovered which predispose specifically to the development of meningiomas. One is called SMARCB1, another mutation in a related gene called SMARCE1, and in yet another family, a different gene called SUFU. My expectation is that there will be many other such genes discovered in the future. But it's quite exciting to begin to understand the origins of these tumors, and our hope is that we will now be able to attack specifically the pathways that give rise to their development. This is an MRI from a middle-aged woman who was having headaches. The headaches were being caused by something other than the meningioma that you see here. The question arose what to do about this tumor. After some discussion, we decided to observe it, and she came back to clinic a year later, and the tumor had not grown. And in fact, we have continued to observe this tumor over the years, and it has remained stable. This approach has been called the watch and wait approach. And I'd like to talk a little bit about the evidence for this approach. There have been quite a few studies that have examined the natural history of meningiomas. Some of these are listed here. And each of these studies has shown that roughly 30 to 50% of these meningiomas will not grow at all over a period of 5 years if you just observe them. So as a result, patients who have asymptomatic meningiomas are frequently watched for a period of time to determine whether they grow. And if they don't grow and they don't cause symptoms, we feel that it's reasonable to just continue to observe them. So when is it not a good idea to watch and wait? This is an MRI of a young lady who had a tumor in her eye as a child and had radiation. The green arrow points to a very small meningioma. We watched this tumor initially, and over time, it increased in size. She'd already received radiation, and the tumor was clearly growing. So watch and wait seemed not to be a good idea going forward. Here's a different case. This is an MRI of a young woman who presented with a seizure. And you can see here, growing along an area called the sphenoid wing, is a meningioma, which is closely associated with the branches of the middle cerebral artery shown here. This is a view of the same tumor from the side. So this tumor caused a seizure. It's pressing on the temporal lobe, which is an area that frequently gives rise to seizures. And we felt that something should be done about this. So what should be done? At the present time, surgical resection of meningioma is still the gold standard of treatment. This usually involves microsurgery, either on the head or the spine. Intraoperative navigation is frequently used. This image is taken from our intraoperative MRI, and we're using this device to find our way around in the head and to locate the tumor precisely. The operating microscope, or in recent years, the endoscope, can be used to carefully dissect the tumor away from surrounding brain and vascular structures. And when necessary, we may actually do functional mapping of the brain in order to identify critical areas and preserve them. The goal of surgery is complete tumor resection without injuring surrounding brain or blood vessels. Here is the MRI that I showed you previously of the young girl with the growing tumor. And this is her MRI after the tumor has been removed. She did quite well after the surgery, and that's the usual outcome for tumors in this area. The risk of significant disability or death in these cases is less than 3%. However, these risks do increase with increasing age over 65, the presence of other medical conditions, or the location of the tumor in or near critical areas. This is the MRI from the other patient that I showed you earlier. The sphenoid wing skull-base meningioma shown there by the green arrows. This is her postoperative MRI showing complete removal of the tumor. And again, she did well and had resolution of her seizures. What are the complications associated with surgery? This table is taken from an article by Wong et al., which was published in Neurosurgical Focus in November of 2012. And I've highlighted the areas pertaining specifically to meningioma in red. This table lists the frequency of complications that occur with meningioma surgery. For example, new or worsened neurological deficits occur in approximately 5% of cases. Tumor recurrence can occur in 0 to 18% of cases, depending upon the tumor location and the grade, and we'll discuss that further in a few minutes. Peritumoral edema occurs in about 2% of cases. Postoperative seizures occur in about 1% of cases. Medical complications in about 6% of cases, and wound infections in about 4% of cases. So in general, surgical resection of meningiomas is a relatively safe procedure, although it does have some risks. Cahill and Klaus used a large public database to examine the records of over 12,000 patients who were diagnosed with meningiomas. And they showed, as shown here in the red line, that patients who undergo resection of their meningioma have a better survival than patients shown here in the blue line who do not undergo resection of their meningioma. The patients indicated in the green line had an unknown treatment. So it appears that surgical resection of meningioma overall improves survival. But what about meningiomas that are difficult to resect, or cases where some residual meningioma is left in order to preserve critical structures? This is an MRI of a patient who has a cavernous sinus meningioma. The blue arrow points to the tumor, which is located in the cavernous sinus, a critical area that contains numerous nerves that control the eye and face. Although some surgeons do attempt to remove tumors in the cavernous sinus, we now know that this is often accompanied by injury to these nerves. And so many surgeons have elected to treat these in a different way, namely with focused radiation. Treatment of cavernous sinus meningiomas and residual tumors in other delicate areas can be accomplished with stereotactic radiosurgery or fractionated stereotactic radiotherapy. This is a type of radiation that delivers a highly focused dose of radiation to the tumor. This can either be done in a single dose or as a fractionated treatment plan. The basic concept is that numerous beams of radiation are applied from different angles, with the tumor being at the focal point, so that the tumor receives a high dose, but the surrounding brain receives a low dose. There are many different devices that are used to deliver stereotactic radiosurgery or radiotherapy. Some of the brand names include Gamma Knife, CyberKnife, Novalis, Linac, Proton Beam, and others. However, the basic concept is the same. They all deliver radiation by applying doses from different angles. The risks of radiosurgery and radiotherapy are low, but not zero, and they include damage to the surrounding brain, brain edema or swelling, a failure to control the tumor growth, delayed development of other tumors, and delayed malignant transformation of the residual tumor. Again, these risks are low, but not zero. The indications for radiation treatment of meningiomas include tumors that are grade 2 or grade 3 in histology, evidence of tumor growth or recurrence, small size, usually less than 3 centimeters, cases where there's a high risk that the resection will result in a neurological deficit, or cases where the patient has medical issues that make them a poor surgical candidate. This is a table taken from a paper by Bria et al., where they looked at the outcome of radiotherapy for meningioma and found that this varies with grade. Low-grade meningiomas are well controlled by radiosurgery or fractionated stereotactic radiotherapy, as shown here. Even after 60 months or 5 years, the control rate approaches 90%. For the grade 2 tumors, however, the curve looks very different. These tumors are less well controlled by focused radiation. In this particular study, there were only 2 patients who had grade 3 tumors, and those 2 tumors did not respond to radiation. I can say in my own experience, grade 3 tumors are more resistant to radiation than grade 1 and grade 2 tumors. However, they do often respond to radiation treatment. Pollock et al. Looked at the factors that predict the response to radiosurgery. They found that tumors that had already failed external beam radiation treatment, as shown here, were less responsive to radiation than those that had not been radiated previously. This applied both to survival of the patients, but also to local control of growth of the tumor. In addition, tumors that were large, greater than 14.6 cubic centimeters, that's about 2.5 centimeters in diameter. Those tumors were less responsive to radiation than small tumors. And as we showed already, tumors that have a higher histologic grade are less responsive. Now, meningiomas can recur. This is a series of MRI images from a patient who presented to the emergency department with headaches. And you can see this large parafalcine meningioma, which includes and involves the superior sagittal sinus. She underwent a near gross total resection, but a very small residual of tumor was left attached here at the level of the superior sagittal sinus, which is a large vein that drains blood from the head and was felt to be open at that time. Although the histology was a grade 1 tumor, the tumor did recur within about a year. And in fact, if you look at studies of this phenomenon, it turns out that meningiomas do have a gradual rate of recurrence, which increases with time. So the percentage of patients who are free from recurrence declines as the years go by. For this reason, patients who've had meningiomas that have been removed should be followed with serial imaging. What factors affect recurrence? This is a table taken from a review article by Rogers and Mehta, where they looked at a series of studies that examined the recurrence rate of meningiomas after a gross total resection, or GTR. And they showed that at 5 years, about 7 to 12% of patients will experience a recurrence, even if the entire tumor was removed at the time of surgery. And that number increases to about 20% at 10 years, and maybe even higher at 15 years. In patients who had a subtotal resection, the recurrence rates are significantly higher. So those rates approach 47% in some cases at 5 years, and can exceed 50% at 10 years, and are in the range of 70 to 90% at 15 to 20 years. So you can see the importance of following up with your physician to make certain that the tumor does not recur, even if it has been removed completely. And finally, tumor grade affects meningioma recurrence. You can see that the benign tumors at 5 years out from surgery, 88% of the patients are still free of any tumor. That means 12% of the patients have experienced a recurrence. For the atypical grade 2 meningiomas, 59% of patients are free of tumor. That means almost 40% of the patients have experienced a recurrence at 5 years. And for grade 3 anaplastic meningiomas, 28% of patients are still tumor-free at 5 years. That means almost 75% of the patients will have had a recurrence at 5 years. So this is a MRI from one of my patients who presented with an anterior skull base meningioma. And he underwent a operation, and we achieved a complete removal of the tumor. And he did well. The pathology showed a grade 2 meningioma. And the question arose, should we radiate or not radiate? As I said earlier, grade 2 tumors do have an increased risk of recurrence. I will just say up front that the answer is unclear. The jury is still out, and there's a clinical trial ongoing to answer this question definitively. However, there is some evidence in the literature which suggests that radiation is helpful in these cases in reducing recurrence rates. This is data taken from a paper by Kumatar et al., published in the Journal of Neurosurgery last year. They looked at a series of patients who had grade 2 meningiomas, and they divided them into those who had postoperative radiotherapy and those who had no postoperative radiotherapy. And you can see that those who had radiotherapy had a lower recurrence rate than those who did not. Importantly, the p-value for statistical significance did not quite reach the 0.05 level. So this was a trend, but there's still a small possibility that this result could be due to a random occurrence. And for this reason, a larger clinical trial, a prospective trial, is now underway to try to answer this question definitively. Based on the knowledge that we have now, it's up to the physician and the patient to determine whether postoperative radiation is needed after complete resection of an atypical or anaplastic meningioma. This is another important question, and that is biological progression of meningiomas. This is an MRI of a patient who has multiple meningiomas. You can see one of those here. He's had multiple craniotomies for removal of meningiomas and has had numerous rounds of radiation. This is a scan that was taken in January of 2012. This is a scan that was obtained 1 year later. You can see that a large tumor has grown in 1 year. Prior to this time, the meningiomas that he had were slowly growing. And so this tumor has clearly progressed. He did undergo operation and a complete removal of the tumor, had further radiation, and is doing well at this time. But what about tumor progression? So it turns out that if you take DNA from the initial tumor or the recurrent tumor and you compare it, you can see that there are some new genetic defects that appear. This is DNA from an initial tumor in a patient, and this is from the recurrent tumor. This is from a different patient. Here you can see some new abnormalities in the DNA as indicated by this red color. It turns out that most of the tumors where this occurs have a loss of NF2, and numerous studies have shown this association between meningioma progression and loss of NF2 in meningiomas. We were interested in this phenomenon and identified a gene which is located close to the NF2 gene on chromosome 22q, and when chromosome 22q is lost, this gene is also deleted. This gene is called CHEK2. It's a known tumor suppressor gene that regulates DNA. I've shown here a slide which is turned on its side, which depicts the process of cell division. As the cell is dividing, the DNA first replicates, and then the chromosomes pair together along the midline. And there's a lattice work within the cell, which is organized by these yellow structures, which are called centrosomes. As the cell divides, half of the chromosomes go to one side, the other half, a matching set, go to the other side. And then the cell divides so that each cell gets an equal copy of the chromosomes. So you can see that it's very important that the cell have these two chromosomes, or rather two centrosomes, to allow the chromosomes to separate equally. This is data from our laboratory looking at a cell. We can see the nucleus of the cell in blue, and the centrosome has been stained with an antibody that marks it red. So this is a resting cell with one centrosome. The DNA has not been replicated at this point. This is a cell that's undergoing division. Now the two centrosomes can clearly be seen with the chromosomes of the DNA lined up in the middle, ready for cell division. If you get rid of the CHEK2 gene, you can see that the cell begins to make extra centrosomes. And when it divides, there are now multiple centrosomes on either side. And as a result, when the chromosomes separate, they don't separate evenly and appropriately. This causes genomic instability and enables tumor progression. We actually demonstrated this in meningioma cells, where we took either the normal cells or cells where we deleted the CHEK2 gene and irradiated those cells to generate a small amount of DNA damage. You can see that the control cells are easily able to repair that DNA damage, but the cells that don't have the CHEK2 gene are unable to repair that DNA damage, and you can see evidence for that damage here. So we've developed a model for meningioma progression in which first a mutation in the NF2 gene occurs, then the matching chromosome 22q arm is lost, and along with it the CHEK2 gene is lost. And this ultimately leads to an increased number of centrosomes and abnormal separation of the chromosomes, leading to meningioma progression. So what can be done for tumors that are resistant to radiation and that can no longer be surgically resected completely? There are a number of agents that have been used to treat meningiomas, including hydroxyurea, bevacizumab, also called Avastin, hormonal therapies, DNA-damaging agents, somatostatin analogs such as octreotide, and kinase inhibitors. Only 3 of these medical therapies have been recognized as having some biological activity in meningiomas: hydroxyurea, interferon alpha, and sandostatin, which is a somatostatin analog. Unfortunately, these agents have shown only limited success in controlling meningioma growth. Our hope is that recent advances in genomic sequencing will lead to new targeted molecular therapies for meningiomas. So this table summarizes what we've talked about today: algorithm for treatment, and serves as a guideline for treating patients with meningioma. The table is from a paper published by Simone et al. In Neurosurgical Focus in 2011. They indicated that they would use a branch point of an age of 65, and I've indicated in my own practice that I use an age of about 75 for determining which of these algorithms to follow. For patients who are under the age of 65 or 75 who are asymptomatic, I initially recommend observation with serial imaging and clinical follow-up. If that observation reveals that the tumor is growing, then I generally will recommend surgery, unless the tumor is in a delicate location, for example, the cavernous sinus. And in those cases, I would recommend stereotactic radiosurgery or radiotherapy. For patients who are symptomatic, the primary treatment is surgery, unless, again, the tumor is in a place where it cannot be safely removed, in which case I would recommend focused radiation. Once the tumor has been removed, adjuvant radiotherapy can be considered depending upon the grade. For grade 3 tumors, I always radiate afterward because of their high risk of recurrence. For grade 2 tumors, it's up to the individual patient and physician to make that decision. In patients who are older, their surgical risks are increased, so they have a slightly different algorithm. If they're asymptomatic, again, I recommend observation. And if the lesion is growing, I can make a decision about whether it should be treated with surgery or with focused radiation, depending upon the patient's health, the size of the tumor, and the risks associated with surgery. If the tumor is symptomatic and is small, one could consider focused radiation up front, although surgery is still an option if the tumor is in an accessible location and the patient is in good health. For large tumors greater than 3 centimeters that are symptomatic, close monitoring is an option if the growth rate is very slow and the symptoms are not severe. If the symptoms are severe, then surgery can be considered. So that concludes my seminar for today. Thank you very much, and I'm happy to take any questions.
Thank you, Dr. Johnson. There's a question here that reads, if a high risk is radiation and gamma knife, etc., are radiation, can you help us understand the risk factors and the percentages in choosing this technique?
Right. So I would say that I would not categorize radiation as high risk. What I would say is that it has risks just as surgery has risks. And we have to balance the costs and the benefits of each in each circumstance. You could see from the tables that I showed that with time, the ability of radiation to control the growth of the tumor declines. And it declines faster with increasing grade. So in those cases where there's residual tumor and the grade is grade 2 or 3, the risk of recurrence is high, and there's good evidence that radiation will decrease the risk of recurrence. Some practitioners will radiate meningiomas without knowing the grade. I do not recommend that unless the tumor is in the cavernous sinus and has been shown to have a slow growth rate. Tumors that have a fast growth rate should be removed if at all possible, because they're likely to have an increased grade and have an increased risk of recurrence. And the best way of controlling their growth is surgical removal.
Thank you.
Did that answer the question?
We hope so. Otherwise, we'll get more, I'm sure. There are 2 questions here that are coming from people with breast cancer histories. The first question asks whether she should be getting, her tumor may or may not be operable, that it's being watched, and she is concerned as a breast cancer survivor if there's something special that she should be concerned about, or some type of treatment that she should be pursuing right now. And if I may tag along to that, the second person is concerned about taking tamoxifen with the diagnosis of the tumor. So if you might address those 2 for our audience, please.
Right. So let me start with the second question. I think that tamoxifen is designed to antagonize the effect of estrogen. And so I do not expect that that would promote the growth of meningioma. So I think that would be fine. With respect to the other question, as I said, there has been an increased risk of meningioma in patients who have breast cancer. The causes for this are unclear, but I would say that in the most recent genomic studies of meningioma, in at least one case, they did identify a BRCA1 mutation. And the gene that I talked about, the CHEK2 gene, separately predisposes to development of breast cancer as well. So these underlying genetic factors may be the explanation for the association between breast cancer and meningiomas. Having said that, there's no evidence at this time that meningiomas that occur in breast cancer patients behave any differently than those that occur in the general population. And so I think that the treatment algorithm that we discussed would apply equally to meningiomas in patients with a history of breast cancer as it does to everyone else.
Thank you, Dr. Johnson. There seems to be another theme of questions here in connection to the genetic risks associated with the tumor and
yes.
testing that specifically, is there genetic testing that could assist the patient and family members with future risk of this cancer? And furthermore, another question asks, would the relationship down to a cousin be something of concern?
Right. So again, I'll start with the second question. In general, when we consider family history, we look for first-degree relatives, parents, siblings, children, to try to assess that risk. Cousins would be considered only if there are also first-degree relatives who have the disorder. With respect to genetic testing, we've not yet reached a point where we feel that this is necessary. The vast majority of meningiomas appear to occur out of the blue, if you will. In those cases where there's a strong family history of meningioma, there's recent evidence, as we discussed, that there may be genes that are identifiable today that weren't identifiable even a year ago. We have not yet changed our practice with respect to that, and I I guess I would have to say that only in those cases where there's a very strong familial component would I consider genetic testing at this point.
Would you care to comment on what you would consider a strong family component or a strong component?
Yeah. So in a patient, for example, who had multiple meningiomas themselves, and where there was at least 2 first-degree relatives who also had meningiomas, I would consider that a strong familial history. Those patients may have an underlying genetic disorder that predisposes to the development of meningiomas, and in that case, genetic counseling might be helpful. So, for example, patients who have NF2, which is the example that we're all familiar with, those patients will frequently have a family history of meningiomas or vestibular schwannomas and would benefit from genetic counseling. And in those cases, there's a genetic test for that. The new genes that have been discovered, there's currently no genetic test, no commercially available genetic test for that. But if there is a strong family history, one can presume that there is a genetic defect that predisposes to that, and based on the pattern of inheritance, they could receive genetic counseling, which would be helpful in family planning, for example. What we do not do as a matter of routine is screen family members when a patient presents with meningioma, because the vast majority of those patients do not have a strong family history, and we have no idea what genes may predispose to the development in those cases, other than the ones that we've discussed today.
That was great. Thank you very much. Here's another question. Proton radiation is the newest form of focused radiation, states the question. Do you have an opinion about its effectiveness compared to CyberKnife or the other treatment protocols?
I think the question, speaking as a person who is a neurosurgeon and not a radiation oncologist, the question for proton therapy is not really effectiveness, it's safety. So in cases where the tumor is adjacent to critical structures, such as the brainstem or the optic nerve, protons can be delivered in a way that limits the radiation exposure to those surrounding structures. So one is able to deliver a full dose of radiation to the tumor more safely than you can with standard gamma knife, CyberKnife, LINAC, etc., photons. The biological effect on the tissue is similar. And so for the vast majority of cases, there's no real advantage to proton therapy over other types of stereotactic radiation.
Thank you. Here's one in connection with diet and lifestyle. Do you have any recommendations that would contribute to reducing the recurrence of meningiomas?
I am not aware of any clear evidence that changing one's diet can affect recurrence rates. This is an area of tremendous study, discussion, and debate, and there are claims on all sides. But in terms of scientific studies of the effects of diet on meningioma recurrence, I have not encountered studies that are done in such a way that kind of hold up to the standards of modern science. I do think, in general, that as we hear from our physicians and in the lay press, it's good to have a diet which is low in fats, low in sugars, that's nutritious, not only because there's evidence that high-fat diets predisposed to development of all kinds of cancers, but also for other health reasons which are associated with being able to undergo any treatment down the road if there is a recurrence. So there's certainly a lot to be gained by eating a healthy diet and exercising if you have been diagnosed with meningioma or treated with meningioma. But I'm not aware of any dietary recommendations that have been shown to make a difference in terms of recurrence rates.
Thank you for your comment on that. Here's another question. If you can please explain correlation between a meningioma and fertility or infertility.
Well, that's a good question. I'm not sure that I know the definitive answer. There may be a study on this. I do think that there is a hypothesis that meningiomas are more common in women because of the hormonal changes that occur during the menstrual cycle, and that, of course, these changes occur from the time of the onset of menses until the time of menopause. And one might hypothesize that in women who don't undergo those menstrual cycles, that the driving force, if you will, for meningioma growth would be decreased. I'm not sure whether there's a study that has been done to look at this. I wouldn't be surprised if there is. But that would be sort of my thought about a possible association between those things.
Thank you for your comment on that. A person writes in to say that her meningioma was called secretory. Can you talk about that?
Yes. So there are many different histological types of meningioma. This is a classification system that is separate from tumor grade. Some of these types, however, do tend to cause more problems than others for patients and do tend to have a higher recurrence risk. And the secretory meningiomas are meningiomas that are thought to release substances which can promote brain edema in particular. And so a very small tumor can have a big neurological effect because of the brain edema that's associated with it. The treatment for these tumors is similar to the treatment for other meningiomas, which is complete removal as a first step. And depending upon the histological grade, a decision can be made about whether there's any need for further treatment with radiation. But we do see these secretory tumors, and when we see a large amount of edema associated with them, even if they're not growing, we will frequently remove them because they are often symptomatic.
Thank you. I'd just like to make a note here that it is 3 o'clock. Prior to the recording, Doctor agreed to go on with questions for another 10 or 15 minutes or so. So we'll continue to have conversations with Dr. Johnson. Another question that I'd like to pose to you from our readers or from our audience today is if there are any, if you know as to whether there are results on sandostatin hormone therapy for recurring grade 3 meningioma and post-radiation and surgical resection.
Yes, so there have been several studies looking at sandostatin or octreotide. It's a somatostatin analog which binds to a receptor on the surface of the meningioma cells and inhibits the growth of these cells. What these studies have shown is that in some tumors, the growth is inhibited by this agent. Many of the tumors did not respond, but some of them did. And given the relatively low number of agents that are available which can inhibit the growth, this is one of the agents that we frequently turn to when radiation and surgical options have been exhausted. So for patients who have grade 3 meningiomas and they've already had surgery and radiation, I think it is certainly worth trying this agent to see if it will decrease the growth of the tumor. It has been reported to do this in several studies, but all tumors do not respond, unfortunately.
Here's another question. Without a biopsy, what determines the tumor grade upon discovering the tumor? And the second part to her question is, with regard to watch and wait, are there specific predictors for tumor growth aside from past growth patterns?
So I don't think that there's a way to determine the grade definitively without obtaining the tissue. Radiologists have been trying to predict tumor grade based on MRI characteristics, and we do use this as a guide or rule of thumb, but it's not certain enough to base treatment decisions on those kinds of studies. So at our institution and at other institutions around the country, a tissue diagnosis is necessary in order to determine the grade. What was the second question? Second part of that question?
Just bear with me a second. The audience is very inquisitive today. We have lots of questions, and I've kind of scrolled past that. No, I'm sorry. I can't find it now. I guess it was, how could you tell the grade? And you say you couldn't. And then, here it is. With regard to watch and wait, are there specific predictors for the tumor growth aside from past growth patterns?
Yes, there are some clues as to whether the tumor will grow quickly or not, but again, it's you have to take a proof is in the pudding approach. So tumors that are heavily calcified, for example, frequently are slower growing, although that is not always true. Likewise, tumors that occur in older patients over the age of 65 tend to be more slowly growing. So these are some indicators of growth pattern. Patients who have large tumors but who are asymptomatic, this may be an indicator that the tumor is growing slowly. But in the end, there's no substitute for obtaining serial imaging and determining the growth pattern that way.
Thank you. With surgical advances, have there been strides made towards more minimally invasive procedures to remove meningiomas and what might be considered high-risk areas like the cerebellopontine
angle?
Yeah.
Right. So there is a general move in neurosurgery to use minimally invasive techniques to remove tumors. But I think it's important to remember the overall goal. The overall goal is to remove the tumor in the safest way possible. That may involve a minimally invasive approach, or it may involve a more open procedure so that one is able to see the critical neural structures in detail and preserve them. So, we take an individualized approach to each case. We have used the endoscope to resect tumors in cases where we thought we could do this safely. But in cases where we believe that there's going to be a need for very careful dissection and there are numerous critical structures in the area, we will often take a traditional open approach in order to maximize the safety for the patient.
Thank you. Here's another question asking if there is any research supporting an association between meningioma and sleep disorders.
That's a very good question. I'm not aware of any studies along those lines, although I would be happy to look into that and to respond to that question in the next day or so.
Thank you. That'd be great. Also, here's another question. Is there a time frame of continuing Keppra after surgical removal of a tumor grade 1 if there were frontal lobe seizures caused by the tumor?
Aha. So this is a very good question. And my general practice is to maintain patients on an anticonvulsant. It's usually Keppra these days, although there are some others that can be used, for a period of several weeks after meningioma surgery to reduce the risk of seizure. In patients who presented with a seizure, I generally will maintain that anticonvulsant for a longer period of time, and then we'll work closely with our neurology colleagues who specialize in seizure management in order to find a time to stop those medications. Oftentimes, we will perform an EEG to look at the brain waves to see if there's any evidence for a pre-seizure waiting to happen. If there is, then we will usually maintain the anti-epileptic medications for a longer period of time. If we don't see that activity, then we feel more confident in decreasing the seizure medicines. It's important to remember that the seizure comes from the brain, not from the tumor. So even though the tumor is removed, the seizure focus may still be there. And so it's important to proceed cautiously before reducing the anti-epileptic medications.
Thank you. And taking that theme again of seizures, there was a question that asked if it could be the seizure is being caused by the scar tissue, if you will, as opposed to with the tumor being gone, could the scar tissue contribute to the occurrence of seizures?
Absolutely. And, you know, one of the risks of surgery, as we showed in the table earlier, is seizures, which can occur in about 1% of cases. That occurs because of scar tissue that forms on the brain. The tumor itself can injure the brain. I often say to my patients, consider the situation where a rock falls on your foot. You can remove the rock, but it doesn't mean the foot is okay. The same is true of the meningioma. It's pressing on the brain, so we can remove the brain or remove the tumor, but then it's up to the body to allow the brain to recover from that. And sometimes there is some scar tissue that is there or an injury to the brain that was caused by the tumor itself. That's what caused the patient to present with a seizure. And that area may still be there and can still generate seizures. Oftentimes, when you remove the tumor, the seizures will go away, but not always.
Thank you, Dr. Johnson. I'd also like to just make a general announcement in connection with the background sounds. We deeply, deeply apologize for this. There was a network issue here internally that we were unaware of, and I'm very, very sorry. There are just a few more questions. I know it's getting very late now. There is one short question, and the person asks, what is an empty cella?
An empty cella is an area in the bone where the pituitary gland normally sits. Sometimes a pouch of the arachnoid, which is a membrane that surrounds the brain, can extend into that area and fill with spinal fluid. And so when you take an MRI, it looks as if there is nothing in the cella, and we call that an empty cella. That can sometimes occur in patients who have increased intracranial pressure, and sometimes it can be an incidental finding.
Thank you. Another person writes in to say that she has had 14 meningiomas, all on one side of the brain. No one seems to be able to tell her why this is happening. Do you have any ideas?
I have some thoughts about that. Of course, I don't know the answer. But it is certainly the case that during development, our bodies become lateralized. So the right side is not exactly the same as the left. That's certainly true for brain function. Speech in most people is localized on the left side of the brain, not on both sides. The heart is on the left side of the body, not on the right, in most people. And that lateralization is controlled by specific genes that are involved in our development, and it occurs very, very early during embryo development. At least one of the pathways that's been implicated in meningiomas, the sonic hedgehog pathway, is involved in early development. And so it's possible that the gene that is contributing to the development of these meningiomas is expressed primarily on one side of the body and not on the other. I think it would be very interesting to look carefully at the DNA of these tumors to try to understand what mutations are driving it, and that may give us some further understanding of how meningiomas develop. But I would imagine that it's due to differences in gene expression between the right side of the body and the left side of the body, and we know that that does occur for certain specific developmentally related genes.
That was great. Thank you very much. So now one final question, pretty straightforward. How do you grade tumors?
Well, the World Health Organization has published a series of criteria that pathologists use when they look at the tumor tissue under the microscope. And the criteria is related to the density of the cells, the nature of the nuclei, how do they appear, are they regular or irregular, the density of blood vessels within the tumor, the organization or disorganization of the tumor tissue, the presence of dead tissue within the tumor, which can sometimes be an indication of rapid growth, and other criteria. And so the pathologists look at the tissue and they compare it to this list of criteria, and then based on that, they will assign it either a grade 1, grade 2, or grade 3.
Very straightforward. There you go. Thank you. That's all we have time for today. Thanks to all of you for joining us. And thanks once again, Dr. Johnson. We appreciate your taking your valuable time to join us today and acknowledge your association with Harvard and the Brigham and Women's Hospital.
Thank you very much for having me.
Okay. We're going to pause for just a minute to conclude our webinar recording and then follow up with a few comments.